disc damage. He was not compliant with the medications and he was lost to follow-up multiple times. So we have taken it up for both cataract surgery and iSTENT Inject. Over to you, Dr. Sahebaan.
Thank you. 2.2. So I'm sitting temporal to the patient. We've already spoken about how the mixed positioning is done. So over here, I can also see that the patient is dilated. Ideally, when I do the mixed procedure before doing the cataract surgery, I prefer not to dilate the patient and dilate them intracamerally. 2.2, please. So I'm going to start by making my temporal incision. For me, it's usually 2.2 because if I'm doing a cataract surgery following this, I prefer to make just a single incision for a better self-sealing incision. So the important thing over here is that you make the incision completely clear corneal. You want to stay away from the perilimbal blood vessels so that there is no bleeding and you don't have a messy field. I think another disadvantage of the patient being dilated is that there is more chance of injury to the anterior lens capsule. Biohalar. I think my mic has fallen down. This is biohalar, that's fine. Cornea wet. So now I'm forming the anterior chamber with a 1.4 sodium hyaluronate. And now I'm going to tilt the patient's head. So tilt your head to the left side. A little more. Okay. Can somebody tilt the microscope as well? So basically, there is no objective way of knowing how much the head is tilted. And we ideally say 25 to 35 degrees or 35 to 45 degrees, but this is basically your assessment at the time. And if need be, you can, how do I eyepiece up? Chin up a little bit. Okay. Biohalar and the prism. So now I also prefer to put the sodium hyaluronate on the cornea as well, because it doesn't flow out from underneath your lens. This is an eye prism SX, and I've lately shifted to this because it gives me a wider, a sharper view. And it's also, I think another advantage is that it's also a little self-retaining more than the Swan Jacob.
What's the cost of this lens?
It's about 6.5, close to 6.5. It's a disposable lens, ideally, but as long as you can maintain it, maybe 3 to 4 times, you can ETO and reuse it.
What happens after that? It gets hazy or something?
So there are, it's like what happens to your spectacles. You get scratches and the view just becomes a little blurred.
Okay.
Okay, so now I also want to take a minute to explain and the angle structures over here. So we have a very good on-fast view. When we say on-fast view, we basically mean that the trabecular meshwork should be staring at you. And now over here, is it clear? Should the illumination increase?
No.
Very clear. Okay. Okay, so this brown band is the trabecular meshwork. You can see the root of the iris, You can also see the concavity in the iris. That means the anterior chamber is very well formed, and the scleral spur also. So next, what I'm going to do is find a site for placing the iSTENT. There can be a little struggle in entering with your instruments with the head tilted. So it's okay to zoom out so that you can enter the anterior chamber and then zoom in again for a better view. You can leave it, but it's always nicer to hold the lens because it doesn't claim to be self-sealing. It's just an advantage. So once you've entered, see, again, with the iSTENT, it's extremely important to have a very, very good magnified view, because these are very tiny stents. You need to visualize where they're going. So take as much time as required to make sure that your view is clear. So now this is the stainless steel insertion tube which I've entered. Now when you pull the green button back, you're able to retract the sleeve. Is everyone able to see the stent in there? There is a sharp needle, that's the trocar, and through the outlet you can also see the stent. So I know that the stent is there. Next, the next step for you would be make sure that your hand is perpendicular to the trabecular meshwork and you have no trocar bias. We spoke about the trocar bias in the morning. So that's it. It's very simple. I made sure that the trocar was perpendicular and now the stent is beautifully placed on the trabecular meshwork. The second stent will be at least 2 clock hours apart. Now I'm able to see a second stent also which has got activated. Again, your hand movements, your hand position should be such that the trocar is perpendicular. Centration. Can you see this? So the second stent is also there. I hope the it's sharp. The image is sharp enough. Yeah. Okay. So now we have 2 of these stents. They are at least 2 clock hours apart in the nasal quadrant, and they're sitting beautifully on the trabecular meshwork.
So do we need to push that? Yeah, that's a little bit of mobility. Is that okay?
Yes. So this one I have pushed a little. So it's always good to nudge it a little to see if it's in the right place and it's not moving. So this one is absolutely fine. This one I had to push it in a little, but now it looks like it's in perfect position. Right?
Yeah, perfect. So is there any specific tips that you would like to share, saying where you would choose your next stent to be placed? Is it just the 2 clock hours away, or based on the pigmentation of blood that you see in the Schlemm scanner?
So ideally what I do, which I did not do today, is mark the area where the stent should be placed. It's where you see the maximum episcleral veins, the vessels, and with a marker ink, you can actually make a spot where you would pre-plan your stent placement to be. And also, I think a very important tip for beginners would be that it's not necessary that you place both the stents in the same sitting. Initially, when I started too, your hand has to be perpendicular. That is I think the most paramount tip that I would want everyone to take back home. So it's okay if you put in one stent and maybe adjust your microscope, adjust your hand position and your chair such that the second time that you place it also, it is perpendicular to you. And yeah, and usually this time I got lucky. There was no blood reflux, but Yes, as soon as you place the stent, you can see blood reflux, which is also very easy to evacuate. You just put in some more visco over there and make sure that the stent is in the right place. Another misconception, or let's say another confusion that people have, is that putting the stent before the cataract surgery will actually displace it during the cataract surgery with the turbulence that you're causing in the anterior chamber. But once it's in place, which is how you have checked it, is by nudging it up, down, however you want to press it in a little bit. Once it is in place, it doesn't move. So in all the cases, whether you look at literature, whether you look at surgeons who've experienced it, never has there been a chance where the stents have moved out of the place because of a surgery following its placement. So I think these are a few tips that I would want everyone to take back. And thank you.
Fantastic. Thank you so much.
Thank you.